All right, it is 8:02, so let's get going because we have a lot that we want to do. I want to welcome everyone. I'm Dr. Lauren Streicher, a clinical professor of obstetrics and gynecology at Northwestern University, and I am so happy to welcome everyone to this webinar on behalf of TEL. And TEL is new. It's a new social media company that posts cutting-edge medical information for the very savvy consumer who wants access to true experts. I mean, not just in women's health, but experts in every medical specialty. The physicians who do research, publish the articles, treat patients on a regular basis. So this is really a very, very new approach to getting good information to consumers. And as we get started here, I want you to know that there is a Q&A, so please put your questions in and we will get to that later. But first, I want to start with just a little bit of history. Back in the 1930s, there were two popular Chicago gynecologists, Irving Stein and Michael Leventhal, and they noticed that a lot of their patients with fertility problems had very similar traits, specifically some irregular periods, little extra facial hair, and unusually large ovaries. So they decided to take a closer look. And in the 1930s, there was no ultrasound. So taking a closer look meant major surgery. And what they found was enlarged ovaries with dozens and dozens of little pearl-like cysts. Well, things have really changed, and Stein and Leventhal made their initial discovery, including that it's no longer called Stein-Leventhal disease. It's now known as Polycystic Ovarian Syndrome, PCOS. And today I am joined by Dr. Allison Rodgers to discuss current approaches to the treatment of PCOS. And Dr. Rodgers, of course, is a double board certified reproductive endocrinologist and infertility specialist and an OBGYN who has personal experiences with both secondary infertility and pregnancy loss. She is the director of ambulatory surgery at the Fertility Centers of Illinois and has, 1.3 million followers on social media. I'm really jealous. But unlike a lot of others on social media who dole out expert advice, she actually is an expert. And if you are one of her followers, you already know that you are always going to get accurate information. And even if you are not lucky enough to have Dr. Rodgers as your doctor, you will get information to take back to your own doctor. And as I always say at the beginning of my podcast episodes, if women are given good information, they will make good decisions. And that is Dr. Rodgers. And she is typical of the kind of expert that you will find on TEL. So welcome, Dr. Rodgers.
Oh, thank you so much. What a lovely introduction.
I've been so
I'm
looking
very
forward
excited.
to this. Yeah.
I know. I'm very excited to be here to talk about PCOS. And obviously, it's something that is very common. I think there's a lot of people who have a lot of questions and confusion. And I think that it's really good to help get great information to people that is medically reliable. And I think, like you said, that's the difference between maybe other platforms and TEL. So I'm thrilled to be here.
Well, one of the problems we have is there is so much information and so much that we can discuss. So what I'd like to do, just to kind of get some structure to this, is we're going to divide today's discussion into three basic topics. First, we're going to talk about infertility issues, and then we're going to go to other medical concerns that women have with PCOS beyond the fertility stuff. And then we're going to talk about some of the long-term issues that we now appreciate that we really didn't know about some years ago. The other thing I'm going to kind of just make the assumption that most of the people that are logging on have been diagnosed with PCOS, and they're really interested in what's new. They want to do a little bit of a deeper dive. So we're not going to spend a lot of time on the basics, but having said that, I do want to lay a little bit of the groundwork. And let's start with this. You know, one of the funny historical things is I mentioned Dr. Stein and Leventhal, and they thought that the syndrome was rare. And they thought that the women who were most likely to have PCOS were white and Jewish because all of their patients were white and Jewish. And we now know that that is not the case. So can you please start by quickly reviewing who's at risk for developing PCOS? How common is it? And how do you know if you have it?
So that's a good question. I think there's a lot of things that play into risk factors for PCOS. So it's not inherited exactly like eye color. It's not autosomal dominant or recessive. It's multifactorial. I think people who have a family history of PCOS are going to be more likely to get it. But even if you didn't have a family history, you may get it as well. So truly, like anyone who has ovaries, born with ovaries, is potentially at risk. I think that it is more common than originally, realized. Certainly, as you said, it's not super rare. It's not, in any one ethnicity. We see it across the board. It's about 10% of reproductive age women, which is actually really common.
Yeah.
Um,
But let me interrupt you for a second, 'cause I have a question about that. When you say it's 10% of reproductive age women, are we really capturing all of them? Because you are seeing the women that come to you because they're having a hard time getting pregnant. And so maybe 1 out of 10 women that you see that are actually having fertility problems. But has there been any studies that look at just in the general population? Is it that common, or are we missing them? Is
I,
it?
it, I think that's a great question. I also will say PCOS is not a yes or no type situation. It is a spectrum of abnormalities. So we certainly have people who have to shave their face every day, never ever get a period on one side of the spectrum. And then we have people who might have 30-day menstrual cycles, but maybe they're ovulating a little later in their cycle. So they have a short luteal phase. Maybe they have some symptoms on ultrasound, but maybe they don't have a lot of extra hair growth and other and it's very mild. So I think there's a huge spectrum. And I think that not everyone is easily diagnosed.
Yeah.
And I think that people can go a long time and get missed.
So what should trigger a woman to go and get diagnosed? I'm going to talk about what tests they have, but what should make a woman say, maybe I have PCOS, as opposed to someone who just maybe occasionally misses a period?
Yeah. Well, and it's hard because when you first start getting periods when you're a teenager, it's absolutely normal to have several years where that clock, that rhythm of your brain isn't quite developed enough and you can have irregular cycles. But if you're someone who's been getting your period for at least 2 years and you are still having a lot of irregularity going more than 5 weeks between periods, the start of one to the start of the next one, if you're somebody who notices a lot of extra hair in places you're not supposed to be getting it. We all have hair in some places we don't really want it, right? Around our bathing suit line and other places where we try to get rid of it. But you really shouldn't be having thick, coarse hair on your face.
No.
You really shouldn't have thick, coarse hair typically between your belly button and your pubic area, that male pattern where we see that, people will call it a happy trail or something like that. That's, extra thick hair on your back. Those are places that, or on your chest, is not typical for
No.
somebody who has ovaries to be having thick, coarse
Right.
hair.
With the caveat that there are some families, I mean, if, your mother, grandma, and your
Absolutely.
sister all have some excess hair,
Correct.
you just have to kind of say, okay,
Sometimes,
that's my family.
sometimes it's familial, but also, that's probably though a reason to at least get evaluated.
Absolutely. So speaking of evaluation, not everyone, of course, is going to land in your lap. Most people are going to go to a family practice doctor, or maybe even their internist or their general OBGYN. So what would you say are the appropriate tests that someone should get if they just go not to a fertility specialist, but just to a general doctor in terms of, just to clinch that diagnosis? What are the basic tests that someone should get?
So truly to be diagnosed, I think most of us in the field use the Rotterdam criteria, which really requires 2 out of 3 criteria. So you need 2 out of 3. One is symptoms of irregular cycles, which is really just your history, right? One is an ultrasound with PCOS appearing ovaries. And then the third is signs of extra androgen, which are those male hormones. So either symptoms of extra hair or blood work that shows extra male, typically what we consider male hormones in your system. And so typically what I recommend is a detailed history, of course, and a pelvic ultrasound with what we would call an antral follicle count, where we're counting those little resting eggs. A normal number is 6 to 11. Traditional thinking is that if there's 12 or more follicles, it's considered PCOS. More recent criteria has changed a little bit to 20. So I think if your ovaries have a lot of follicles, so a pelvic ultrasound, a detailed history, and then I do think it's reasonable to get some blood work done. Because extra hair growth PCOS is a diagnosis of exclusion, right? And because extra hair growth specifically can be related to other things like adrenal tumors or other things that people can get, which are certainly rare. I don't want anyone freaking out if they have extra hair that they have a tumor, but this is the reason to get evaluated. So I typically will get some hormones. If you have extra hair, I'll get typically I'll get a total testosterone. I get a hormone called 17-hydroxyprogesterone, and I get a hormone called DHEAS. I'm not exactly sure where those balloons are coming from. Did you see
No,
those?
but I like them.
Okay, weird.
Maybe.
I'm not sure. Anyway, random.
What about anti-Mullerian hormone? Where does that fit into
Yeah,
the whole diagnostic criteria?
so AMH is a hormone that comes from our ovaries, and it comes from the little follicles. And AMH is not in the classic, criterion for diagnosing PCOS. We cannot use AMH to diagnose PCOS. That being said, compared to other hormones we look at to look at how many eggs somebody has, which is luteinizing hormone and follicle stimulating hormone and estradiol, which is looking at sort of where you are in your menstrual cycle, that has to be done at a very specific time in your cycle. AMH is nice because it can be done at any time in the cycle. And especially for women who might have PCOS who don't have regular cycles, it's hard to catch them on that day because sometimes they don't get a period. And so AMH is a very useful tool clinically, but we don't necessarily use it to diagnose people. So a normal AMH for a young woman is sort of 2 to 3, and anything above, in the 4 and higher range is probably PCOS. Now, do I have some patients who don't have PCOS who have high AMHs? Absolutely. However, for people who have symptoms, while we can't truly use it to diagnose, it's a helpful clinical tool to help us figure out how many eggs are sitting in the ovaries. And obviously from a fertility perspective, I use it to help with dosing of drugs.
Right. And it's funny because, of course, your world is the fertility world. My world is the menopause world. So a lot of people, when they have irregular periods and they think it's PCOS, and in some cases it can be something very rare, like
Yes,
a
unfortunately.
premature ovarian insufficiency or premature menopause. So there's a lot of things that we need to, as you say, rule out to get to the right diagnosis. So I want to talk a little bit about treatment. But before I get to that, one of the questions I have is, does everybody need to be treated? Number one. And number two, does this ever just go away by itself? Or is this once you've got PMS, there was a slip. Once you've got PCOS, are you always going to have PCOS?
Yeah, so this is a great question. To the first part of, that question is, does everyone need treatment? And the answer is no. However, for typical people with PCOS who don't have regular menstrual cycles, what really is happening is their pituitary gland in their brain isn't sending those signals down to their ovary to make a mature egg and release an egg. And so they're not producing progesterone from the place where that egg released. Progesterone is very protective for the lining of the uterus. It's protective for a lot of things: breast cancer, ovarian cancer. It's protective for uterine cancer. And what we worry about in people who have PCOS is that they're not ovulating, they're not getting a period, and the lining of the uterus is kind of building, and not shedding appropriately, not being exposed to progesterone. It can increase the risk of uterine cancer. So if you're somebody who has PCOS and maybe has a little longer cycles, but you're ovulating, and you have a little extra hair, but you're ovulating and you're getting regular cycles, or maybe you're on birth control pills for contraception reasons, cool. But I think if you're not getting a period and you're not on hormones, you're putting yourself at risk for long-term risk for health complications like uterine cancer.
Yeah. And I think that that's such an important point, because when we talk about, is it important to get a period? And if you're on birth control pills, no, nobody cares if you get a period. If you have an IUD, no, we don't care. But if you're not, yeah, you need to get a period, because otherwise you are going to get that abnormal buildup in the lining of the uterus and put yourself at risk for uterine cancer down the road. So, we could spend all night talking about treatment, but I just like to kind of just touch on it in terms of, when a young woman, we've got two groups. We have the woman who wants to get pregnant and the woman who doesn't want to get pregnant. So again, I know you could spend a long time talking about the treatment of infertility in the patient with PCOS, but can you kind of just give us a little short version of that?
So, and to go, just to back up one question, to answer the question of, does it ever go away? And
right.
The answer to that question is yes, actually. A lot of times when patients get into their 40s, egg count starts to drop, they start getting regular cycles again. And sometimes this is where we see some people who were never able to get pregnant. Then when their egg count starts to drop and they have more regular cycles, they are able to get pregnant. So typically PCOS does go away. And I absolutely see some people who are at this place where they were like, no, really, I have a high egg count. And I see them and I'm like, you might have had, but you don't anymore,
Yeah.
right? Because we lose eggs.
Well, let me ask you this, because we know that one of the things that's associated with PCOS is women who are overweight. And certainly thin women can have PCOS as well. I don't want to make it sound like they can't. But if someone is overweight and then they get to a healthy weight, is that going to increase the likelihood that PCOS is going to go away?
Not necessarily.
Yeah.
So that's a really tricky thing. So some people carry extra weight and aren't ovulating because of that extra weight. But people who have PCOS aren't ovulating because of the inability of their pituitary gland to appropriately send messages down to their ovary. And that is something that certainly medication might work better, or, they might have lower risks of diabetes, but it's not necessarily going to take that away.
Yeah. If someone has PCOS and they are not able to get pregnant in the absence of other fertility problems, amazing sperm, everything else is fine, everything is good, and they're young, because I know age, of course, is the biggest determinant of successful fertility treatment. So, but how successful is fertility treatment in a woman who's just purely a young woman with PCOS? Can you make that
It's one of my
generalization?
favorite things to treat because
I was hoping you were going to say that.
well, yes, because first of all, I would so much rather if you're going to fall on one side of having too many or too few eggs, too many is certainly easier to work with than too few. But patients have a very, very good prognosis because typically we need to just give them medication to help them wake up that pituitary, to get their body to send that signal of follicle stimulating hormone down to that ovary to grow the egg. And that's all they really need. So usually it's an incredibly successful patient to treat.
Yeah.
Very good prognosis.
Well, we have a mutual friend who's a fertility specialist. And when he first went into practice, he would always thank me because I would send him PCOS patients all the time. And he would say, thank you. I can get them pregnant. And they think I'm wonderful. And it really helped build his practice. So I know exactly what you're talking about. So let's talk about the person who doesn't want to get pregnant.
Yeah.
She's a young woman and she says, okay, I understand that I can't go 9 months without a period, that's not good. So what would you tell that woman in terms of appropriate treatment?
I think there's several options. I think, like we talked about, we want to give these patients some progesterone to help protect the uterine lining. And there's a lot of different ways we can do that, right? So there's different ways that we can administer progesterone. So a birth control pill is an easy one. It actually helps a lot with some acne and hair growth because it helps increase one of what I call the sponge hormone, sex hormone binding globulin. So it soaks up a lot of the extra testosterone and other hormones, and it decreases extra hair growth and some of the other symptoms. So I love regular old plain birth control pills for that, which is a combination of estrogen and progesterone.
And does it matter which birth control pill? Because I think that's a little bit controversial. I've heard all kinds of different things about that.
So theoretically, it doesn't matter. Estrogen plus progesterone, it's going to be helpful. I think there's certainly some progesterones. Estrogen is the same in all pills. Progesterone is a little bit different. And different progesterones have different affinities to different receptors in our bodies. And so some of them are able to work a little bit better for PCOS, but in general, they're all fine. And I agree, it's a bit controversial. We sort of learn about it in fellowship, but I'm not sure clinically in practice
that it really matters. Yeah.
So we can give progesterone as an IUD. We can give progesterone as just a plain progesterone pill that we can give, 10 days a month.
Except that's not contraception. Let's just, throw that out there.
Absolutely not contraception, but it's not going to help you ovulate, but it's not going to prevent you from ovulating.
It's not going to prevent it. Right.
So definitely need to use backup. Thank you for that. Yes.
Like it's not fertility, but it's for people who don't want to get pregnant. It works great in terms of fertility. Triggers an ovulation. Yeah.
But what I would say is that the combined birth control of estrogen plus progesterone is one of the best tools we have to help with some of the other symptoms of just irregular cycles. So some of the annoying symptoms of acne and extra hair growth, which are embarrassing and difficult for mental health, and not good for people's just general wellness, emotionally. And so that's where I think birth control pills for people who are not trying to get pregnant are really, really helpful.
Yeah. No, I think it's important to not minimize those other side effects because while they're not life-threatening, we're looking at quality of life and
Yeah.
people just feeling good about themselves. I want to remind everyone that you can put questions in the Q&A, and I wish someone would just put one in there just so I can make sure a Q&A is working because I don't see any questions yet. So let's talk for a minute about metformin. What is it and who should get it?
Yes. Okay, so metformin is a medication originally designed and developed for diabetes. And one of the things that we find with PCOS is there's issues with the ability of the body to be sensitive to insulin. So while it's not diabetes, PCOS is not diabetes, it's related to a metabolic disorder in the fact that it has patients often have an issue with the way they process and handle insulin. So we use metformin, which is a medication that makes our cells more sensitive to the insulin. And this is a great medication for some people. So as you mentioned, a lot of people, if you have resistance to insulin, can carry extra weight. And metformin can help people lose weight who are trying, which is great for overall health. Also, like long-term risks of, I'm sure we'll get into this, but long-term risks of PCOS, and cardiovascular disease, diabetes, high cholesterol. So, being a normal weight is really, really important. And it helps people prevent diabetes. Now, if you're trying to get pregnant, it can often help patients ovulate. But metformin it sounds amazing. Like, why wouldn't everybody be on this drug?
Right. That was my question. If you're not trying to get pregnant, why shouldn't everyone, be on metformin?
Right. So, but metformin has some really serious side effects. And amongst those side effects include mainly GI side effects. So, severe nausea, horrible diarrhea, and those symptoms typically go away. We start patients on low doses of medication. I like to use extended release medication so it's slowly dissolved into the system and not dumped in really fast. But most patients do have some side effects, and we have to kind of go up slowly over time. I typically will start at a dose of 500 milligrams and go up, usually every week or two, about 500 milligrams to a goal of 1,500 to 2,000. And this is a medication that helps with sensitivity to insulin for not all, but some women. It can help you ovulate. And then I have a lot of PCOS patients who want to stay on medication between pregnancies, even when they're not trying to get pregnant, because they feel better on it. And
Yeah.
even though it has side effects, they have more energy. They feel more, they don't feel sluggish after they eat. Like, they just feel better. And I think that has to do with sort of the way their bodies are processing insulin.
So you've been talking about insulin and insulin resistance, and we know that there's an association of diabetes with PCOS. But my question is it that women who have diabetes are more likely to get PCOS, or are women with PCOS more likely to become diabetic?
It's the second. People who have PCOS are at higher risk for type 2 diabetes. And it's, a lot of us are at risk for type 2 diabetes. But these are patients who, because of the PCOS, have a hard time with, and it's probably not, it's probably like related. I think of it sort of like a Venn diagram, right? Like, not everybody who has diabetes has PCOS, certainly. Not everyone who has PCOS has diabetes, but most people who are PCOS have some issues with insulin resistance. And then it puts them long term, like maybe not when you're 25, right? But long term in life, these are people who are at higher risk for developing diabetes in their life.
Yeah. Okay, so let's talk about other health conditions beyond diabetes that are associated. You touched on cardiovascular disease. I do want to circle back and talk about that a little bit. But, one of the things that I was taught when I was in training was when you have PCOS and you enter menopause, yay, your problems are over. And we now know that that's not the case. So what I'd like you to talk about is other health conditions that are associated with PCOS, both short term while you have PCOS and longer term, because obviously you've already touched on fertility issues. You've touched on a higher risk of uterine cancer. You've touched on a higher risk of diabetes, but there's more, right? So talk a little
Yeah.
bit about some of these about these situations that women with PCOS are more likely to encounter.
Yeah, and it's all ties back to sort of what we would call a metabolic syndrome, meaning sort of the way our bodies process energy. And so patients during PCOS, besides being at risk for infertility, are, for example, during pregnancy at increased risk for things like gestational hypertension. They're at risk for gestational diabetes, which can certainly make them higher risk in pregnancy.
Yeah.
And, like you said, not all patients who have PCOS are overweight, but certainly a higher percentage of them are. And that can lead to pregnancy complications as well. So those are some of the shorter term. In terms of longer term risks, like we talked about, the way our bodies process energy has a lot to do with our overall health. And even after you go through menopause and PCOS is gone, you're still at risk for the metabolic disorders that are associated with PCOS. So when I say cardiovascular disease, this is things like heart attacks, trouble with like plaques and clots in our arteries, right? Things like high blood pressure, things like high cholesterol, and certainly diabetes. These are all conditions that are you're at higher risk if you've had PCOS, in your life. And so that's why it's important, if you've had a diagnosis of PCOS, even if you maybe are now getting regular cycles or you're in menopause and not getting cycles anymore, that you do get general routine care with a primary care doctor or OBGYN, if your OBGYN does a lot of more primary care stuff, and make sure that your heart's healthy, your cholesterol's good, you don't have diabetes, your blood pressure doesn't need to be treated, so that you are not at risk for some of these long-term, really serious medical diseases that so many Americans are plagued with.
And let's be honest, not every doctor, unfortunately, knows this stuff. Don't assume that your internist or your general OBGYN, if you're, 40s or 50, is even aware that the fact that you had PCOS in your 20s is going to put you at higher risk for a lot of these situations later on in life. There's a couple questions that came in from someone named Melissa that I think that you are reading her mind, because every single time she's written a question, you've like answered it 20 seconds later.
Goodness.
Yeah. So
I'm
thank you,
like
Alyssa, for
second.
those. You're channeling right to Dr. Rodgers. So that's great. But another question that came in from Kristen, we did not talk about spironolactone. You had touched a little bit on using metformin for hair growth and all that, but you didn't mention spironolactone. So could you talk for a second about where that fits in?
Sure. So spironolactone is a medication that's used. I think some OBGYNs use it. I think a lot of dermatologists will use it. Primary cares, maybe. I don't think a lot of reproductive endocrines use it on a routine basis, because it actually can cause birth defects if you get pregnant while you're on it. So we don't recommend it while you're trying to get pregnant. But this is a hormone that helps modulate and regulate some of the androgens. So some of those male hormones that people with PCOS may have extra of, this helps with reducing some of those extra hormones. And so over time, it can help reduce extra hair growth. One of the hard things about hair is it takes a really long time. The hair cycle is long. It takes a long time to grow hair. It takes a long time to get rid of hair. And so sometimes it can take quite a while for this medication to work. But it can be a very effective option. And a lot of times I like to use it in conjunction with a birth control pill, because you really don't want to get pregnant on this medication.
Yeah, no, I think that that's the most common scenario in which we are recommending that, because as you said, you got to be really careful with that one. When we talk about the cardiovascular risk, and this is actually relatively new information, because while this has been certainly observed over the last few years, it's really only in the last couple of years that a lot of articles have come out saying, yeah, that if you have PCOS, that because of the inflammatory issues, I mean, I think that's part of the confusing part, is that when you say, okay, people that have PCOS have these other risk factors for cardiovascular disease, the typical risk factors that we all know about, being overweight, family history, high blood pressure, all that kind of stuff. But now there's this understanding that even if you don't have those other risk factors, PCOS in and of itself is going to put you at increased risk. And that's new, that's different, that's big. And my understanding, correct me if I'm wrong, is that this is because of the inflammatory response that a lot of women have with PCOS that causes this buildup in the blood vessels. Is that your
Yeah.
understanding? Is there something else going on?
Yeah, no, I think that that's accurate. I think that it's all tied into sort of how our bodies use energy, how our bodies process our metabolic the ability for us to process energy and inflammatory responses to this can cause plaques in our vessels in our heart, and that certainly leads to this. And so you're right, it's not just PCOS plus obesity. It's the metabolic disorder that causes PCOS.
And that's huge to really have an understanding of
Absolutely.
that. And I think one of the things also is that we really do need to think beyond, of course, the getting pregnant, which is very often your focus. I'm the one that's seeing them later in life. And
Right?
so, yeah, and it's quite frankly not something that I have ever been particularly focused on, because I started to practice in a time when PCOS was really just about either getting pregnant or preventing uterine cancer. I mean, there's no question that you and I have had the
Yeah.
same experience, that normally uterine cancer is not something that you diagnose in a 20-year-old or a 30-year-old or even a 40-year-old. But when we do, more times than not, it's someone that has PCOS. And that's something that we've known for some time. So that part's not new. Okay, but let me ask you this, because I'm in the menopause world. And so I'm now looking at these
Getting
women.
in the menopause world.
Welcome to my world, to the menopause world. But this is the thing, is that when I think in terms of, okay, how can I advise women in terms of doing whatever they can to prevent these long-term problems? So you talked about metformin, right, as something that is going to help in terms of managing this inflammatory response and hoping to decrease the risk of cardiovascular stuff down the road. But so when should someone start it? How long should they take it? And when do they get to stop?
These are great questions, right? I think that
Well,
this
I mean,
is,
I'm trying to, I'm very
yeah,
solution oriented. So I'm trying to get practical
so
here.
well, so these are really complex decision making that really has to do with you and your doctor, right? So a specific patient out there that has to really look at pros and cons of any medication you start. So metformin, while it's a great drug, like I said, has a lot of side effects. And so you have to look at your, the blood work panel, cholesterol, right? Triglycerides, liver enzymes, hemoglobin A1C. We got to look at the person as a whole picture
Mhm.
and really have the conversation of, is there family history of diabetes and heart disease, all of these things, right? Obviously, heart disease and high cholesterol needs to be treated with high cholesterol medicine. We don't do that until you're done having kids. And so I think this is where pulling in your primary care, who's really, making sure that if you're at risk for diabetes, that gets started at an appropriate time. So it doesn't mean you start it when you're 50, when you're in menopause. A lot of people do need to start that earlier. And unfortunately, as our society is getting bigger and bigger, the risk of diabetes is getting higher and higher in everybody. And so, I think that if you have more than one risk factor, including obesity, family history, all that stuff, those are reasons why you may want to consider starting this earlier. And a lot of times people are on it for a long time. Obviously,
Yeah.
people can take breaks and stuff, but it really helps reduce, it treats diabetes, but it helps reduce your chance of getting diabetes. And
I'm
if you're a
gonna ask you,
woman, oh, I was
and
just going to say, if you're
go ahead.
a woman who had gestational diabetes, you're at very high risk of getting diabetes later in life.
You mentioned side effects, the GI side effects. You also mentioned that a lot of people, if they stick with it, those side effects will either get better or go away. Because again, we're talking about potentially long-term therapy. Are there
Yep.
women that it just never gets better. They just can't tolerate the drug.
Yeah, so, I have patients. So, first of all, a lot of doctors will just put people on regular straight up metformin, and that is immediate release. It gets dumped into your system. Your body can have a strong reaction to it. So if you're on regular metformin, you can always get switched over to extended release, which has, because it's slowly slowly metabolized, it gets slowly released into the system. I also start at a low dose. So sometimes I have patients who say, gosh, I got to 1,000 milligrams and I was tolerating it, but when I bumped up to 1,500, I just can't tolerate it. And so then we'll go back to a dose that they're tolerating.
Yeah.
And sometimes instead of going up by 500 increments, we can go up by 250s. And so we can play with the medication and do things as slow and really based on that individual patient. Certainly the goal is to get to 1,500 to 2,000. Some patients can't get there based on symptoms.
It's just finding each person's individual sweet spot, which is always the challenge that we have when we have a situation like that. You'd mentioned, of course, that Americans are getting larger, and certainly we are dealing with a lot of people who don't have a healthy weight and who do have obesity. And a question came in, which is my question as well. What are your thoughts on Ozempic and the like for weight management and insulin management for women with PCOS?
So Ozempic and the sort of semaglutide class, that class of medications, obviously is a newer class of medications. And it's very, very effective in helping with managing diabetes. It's also very effective in helping patients with weight loss. Now, it's not been studied, it's new, so it hasn't been studied like metformin to help with ovulation, right? If we're looking at someone who has PCOS who's trying to ovulate. It's also been shown to be potentially dangerous in pregnancy. Obviously, you don't want to be in a weight loss state while you're pregnant. So the recommendation is that if you are on that class of medication, to stop it for 2 months before trying to get pregnant, right? And so while I think if you are somebody who is not trying to get pregnant and you're having difficulty managing your weight, this is something typically a lot of times you'll start other medications first, and then like metformin first, and then add in or switch over to an injectable like Ozempic or Wegovy in that class of medications. But it's important to know if you're trying to get pregnant, it's not necessarily
Right.
safe.
But
And it doesn't necessarily help you ovulate, but it's a great class of medications. I do think it's going to revolutionize our ability to help treat obesity without surgery.
Yeah, and I think the message really is that in the absence of trying to get pregnant, with the limited data that we have with PCOS, there doesn't seem to be any reason not to take these medications
Absolutely.
based on what we know right now.
Absolutely.
The other thing I want to clarify based on a question that came in is someone asked about research around taking metformin in a cancer diagnosis. And we had really emphasized that metformin is going to help in terms of perhaps avoiding some of the cardiovascular issues down the road. But also, it's not just about the cardiovascular issues, it's also in terms of avoiding uterine cancer and other issues such as that. So the answer is yes. I mean, that it is part of the whole
Yes,
spectrum.
I think that there's enough women who don't ovulate regularly on just metformin, that like from a uterine cancer risk, it's going to be really important that you are ovulating. And so if all you need is metformin and you're having regular cycles and you can do a blood test and show there's progesterone in your system, cool. But I think that I don't want people to be on metformin, not be ovulating, and expect that it's going to protect their uterus. Really, you need progesterone. And so you either get that by ovulating, either with ovulation induction, like fertility drugs, or metformin, but metformin doesn't make everyone. So I just want to make sure we're very, very clear about the fact that you really need the progesterone.
Right. Well, the goal is to ovulate. The goal is to make progesterone. And if metformin's not going to do it, then you need to be taking something else at the same time.
Yeah.
All right. Here's another one for you that I'm guessing no one has asked you before, but maybe they have.
Maybe.
Maybe.
I've been doing this a while.
So we know that women who take hormone therapy within 10 years of their last menstrual period or between ages 50 and 60, that when they take hormone therapy, they have a significant decrease in cardiovascular disease and a decrease in dying from any condition of about 30% compared to women who don't take hormone therapy. We've also established that women who have PCOS are at higher risk for cardiovascular problems. So if a woman with PCOS, the minute she enters menopause, starts hormone therapy, is that going to decrease her risk of developing cardiovascular disease? Now, I will preface that question by saying there's no data on this.
Yeah.
I just want your
It's a
opinion because I
very
have an
good
opinion. I'd love to have your opinion.
True. I've not been asked this question before. Also, though, most of my patients are not worried about cardiovascular health,
Or
when they're trying to
menopause.
yeah. So, it's a great question. And I don't think it probably reduces their overall risk, but they're already at increased risk. So I think you're right. I think it's just speculation and there's not really a whole lot of data on it, but that would, it would be interesting to look at. Lauren, what are your thoughts on that?
Well, my thought is that every single woman should be on hormone therapy, not only to reduce hot flashes and vaginal dryness and for her bone health and her bladder health and her cognitive function, but we know that there are estrogen receptors in every single organ in the body and that there is a great benefit to continuing to take hormone therapy long after someone is having hot flashes. So I think, of course, that when we look at the number one killer of women is cardiovascular disease, and we know that hormone therapy is greatly going to reduce that every woman should take it, but particularly women with a history of PCOS because they have an extra reason why they might be at risk. And I know, we both emphasize about all the other risk factors about, you don't smoke, you maintain a healthy weight, you exercise, blah, blah, blah. I mean, everybody knows this. I don't want to hammer it, but still, it's really looking at the whole spectrum. But I think hormone therapy is certainly part of the cocktail to keep everyone at their best cardiovascular health. So that's my take on it.
And TBD with hopefully somebody will study that. It sounds like a great research project.
I think it would be a very important research project because it is a large population of women that started off with PCOS. And just as we've begun to really just appreciate not only the cardiovascular issues, but even we talked earlier about the pregnancy issues and all of these things that we really just didn't understand. And now as we are seeing these women as they age, we really have to keep track of all of this. We are actually at 45 minutes. And so if there are any other questions, now would be the time. And I'm going to ask you if there's anything I did not ask you that you just are dying to talk about.
The only other thing I would say is that obviously, if you're listening to this, you're interested in getting more information. It's important, as we've talked about, to advocate for yourself. Nobody's going to be advocating for you. And as good as your doctor may be, it's important that you ask the questions and understand what's going on with your body so that you can make good choices about your healthcare.
And I would add to that, because we're always being nice, if you will, and saying, talk to your doctor, talk to your doctor. Sometimes your doctor is simply not an expert. And I think it is a fair thing to say, yes, start with talking to your doctor, but if you get the feeling that he or she really is just not comfortable with this, they might be a great doctor when it comes to other things, but this isn't their thing. And I would encourage women that if they feel like their doctor does not have the expertise, you get another opinion. And you shouldn't feel badly about that. There are a lot of experts out there. They can be found. And that's why it's so important to get this kind of information so that you know the right questions to ask. And then if your doctor is really not capable of telling you what you need to know, well, then look elsewhere. That's okay.
Yeah.
This can be serious stuff, and you need to get the right information. So, and again, just to come full circle, that's what TEL is all about. That's why both you and I are working with TEL, because we are tired of women coming to us with bad information and quote, research or what the latest TikTok star told them. And we spend so much time dispelling the myths, dispelling the bad information, and nothing would make me happier, and I'm assuming you happier, than someone who comes to you with the right information, who's done the work so that you can really give them good advice without having to dispel all the bad
Absolutely.
advice. We waste so much time telling people, no, that doesn't make any sense at all. You shouldn't be doing a green juice cleanse to make, to balance your hormones. Doesn't that make you, we all things that make us crazy. What makes me crazy is the certain foods are going to balance your hormones. No, they are not.
Yes, I do. I will say that, the whole thought of a female menstrual cycle is that, you're in constant, obviously before menopause, you're in constant flux, right? So
Right.
nothing's ever balanced. You're always changing. So
Always, always.
I'm not
That's why
sure
when
what
people say I
balance
want to do a
means.
hormone level, and I'm like, well, that's really not going to help us with anything in most cases, unless it's very specifically timed for a very specific reason. But yeah, eating broccoli is just not going to do it. Anyway, thank you so much. This has been so much
Same.
fun having this conversation with you. And I think people know where to find you, but tell them anyway.
Sure. So you can find me on all social media platforms. So mainly TikTok and Instagram, at dr.allison.rodgers.
And I am at Dr. Strike on Instagram and at Dr. Streicher every place else. And for those of you who like podcasts, and I'm hoping to use a portion of this on my podcast is Dr. Streicher's Inside Information. And we cover all kinds of fun topics. You would be surprised at
I
some of the
can't wait to
things.
listen to it.
It's really quite interesting. Yeah, I have fun talking to people like you and getting all kinds of inside information. And I have all kinds of books out there, and drstreicher.com is my website. So thank you so much. And thank you to the attendees who gave us great questions. Exactly, great questions that we needed to hear, right?
Yep.
All right. And there will be a recording of this. So your any friends who have not heard it, where will it be at? It'll be on the TEL site, I think. So, all righty. Thank you all very much. And I am signing off.
All right. Thank you.